Welcome, everybody. My name is Debbie Gold, and I'm the Assistant Director of Marketing at Nova Southeastern University's Mailman Segal Center for Human Development. We have a wonderful session planned for you today, and I'm excited to bring you this presentation. Before we start, I want to review that the session will be an hour long. It's being recorded and will be uploaded and online, and you'll have the opportunity to view it at your leisure at www.nova.edu/DRA. And we will have that information for you at the end of our presentation if you want to jot it down again. We encourage your questions. So if you're familiar with this technology, what I'd like you to do is submit your questions by going to the chat feature on the panel to submit questions, and we'll be able to help answer your questions at the end of the session. The PowerPoint information is in the materials section, and
unmuted
that at your leisure. I'm thrilled to announce to you our presenter, Dr. Susan Kabot. She is the Executive Director of the Autism Institute at the Mailman Segal Center for Human Development at Nova Southeastern University. Dr. Kabot serves as the Executive Director of NSU's Autism Institute, where she oversees multiple programs for children and young adults with autism. These include an early intervention program, a preschool program, and a college support program. She has been appointed member of the Florida Development Disabilities Council since 2010, and she is the current chair. She is the co-author of 3 books published by Autism Asperger Publishing. I'm thrilled to present you with our presenter, Dr. Susan Kabot.
I want to add my welcome, and I'm really excited that you are all joining me for Autism Awareness Month, and specifically World Autism Awareness Day. So Debbie and I are both wearing blue. I hope there are others of you out there wearing blue along with us. What I'm going to do probably for the next about 45 minutes is just update everybody on kind of trends and the newest information about autism spectrum disorder. I'm sure that, you know, as an audience, you are coming from very diverse backgrounds and very diverse knowledge about autism, and this way kind of get everybody on the same page and up to speed with some of the newest information out there. So I'm going to click off and share my PowerPoints with you. You'll be able to download it in the materials section, and as Debbie said, the recording will be available following this session. So, as Debbie said, I have been here at NSU, and I'm responsible for a variety of autism programs. I've actually been employed here for 34 years, and so I've seen the autism programs grow from the very beginnings to the large range of programs and services that NSU has currently. I'm going to, again, share with you the hopefully newest information in terms of trends and issues in autism, and then hopefully we'll have a good discussion in the last 15 minutes of the presentation. So over time, our understanding of autism has undergone a number of changes. Autism was first recognized in 1943 by Leo Kanner, a psychiatrist at Johns Hopkins University. And since that time, what we recognize as falling under this term autism spectrum disorder has really changed. The DSM, the Diagnostic and Statistical Manual of Mental Disorders, is the diagnostic framework for a number of psychiatric and mental health issues. Autism is one of the conditions that is included there. And as you can see, we're on the 5th edition. There was 4th edition really had 2 different versions. But we are currently on the 5th edition of this classification system. And autism is one of those categories that has changed over time. In the earlier manifestations, it was called childhood schizophrenia. We know right now that autism and schizophrenia are not one and the same thing. The DSM-5, which was published in 2013, took several different categories of this disorder and put them into one spectrum. And that's really our understanding of what autism is now. When it was divided into autistic disorder and pervasive developmental disorder not otherwise specified, and Asperger's disorder, what the research found was that there wasn't a way to reliably figure out who should go in which of those three categories. And so high functioning autism and Asperger disorder really seem to overlap and not have, at the moment, we don't know about a lot of discriminative abilities. So now we have one broad spectrum disorder, and everybody falls under that one diagnostic label. The other thing that was added with the DSM-5 for the first time is that once you give a diagnosis of autism spectrum disorder, you also are going to rate that individual in terms of the need for support. Now, every single person is going to get a numerical value that demonstrates the need for support. So the implied message is that if you don't need support, you don't fall under the spectrum. And people often joke about Bill Gates being on the spectrum, and people say, well, how would you rate him in terms of requiring support? You know, does he need support or doesn't he need support? He's developed this and manages this unbelievable company. So he probably would not fall on the spectrum, even if he demonstrated some characteristics of it. Everybody who's on the spectrum is going to be rated for a level of support ranging from 1, which is just requiring support in general, to level 2, requiring substantial support, to level 3, requiring very substantial support. And that level of support is rated separately for the social communication area that makes up autism and the restricted repetitive behavioral category. Another kind of change or thing that has been changing over time is the increasing prevalence of autism. This graph is from the Autism Speaks website, and it shows from 2004 to 2018 the change from 1 in 66 in 2004 to the current number, which came out in 2018, of 1 in 59. We had two measurements at 2014 and 16 that stayed at 1 in 68, and the question at that point in time was, had the prevalence rate kind of stabilized at 1 in 68? But then in 2018, we see again the increase to 1 in 59. Now that number was obtained through the Centers for Disease Control, Autism and Developmental Disabilities Monitoring Network. And what they do is they go in and look at school records and health department records of 8-year-old children. And they've picked 8-year-old children because it's thought that by that point in time, children have been in school for a couple of years. And so most individuals would be identified by that time. So they look at these records and look for indications of autism. And that's the way they count those children in that process. There is another study that was published in 2019, more current, that also has been done in the past, but in this 2019 found a prevalence rate of 1 in 40. Now, the way they do it is they call households, large number of households, and ask the question, is anybody under the age of 18 diagnosed with autism? And so it's really parental report or family member report, and that is showing now 1 in 40. And so we do know that, I think we can all agree that the prevalence rate of individuals with autism is still continuing to increase. In terms of other demographics, what we've seen is that the ratio of males to females has stayed pretty steady, ranging from 4 to 5 boys for every girl on the spectrum. And of course, there is a lot of discussion about whether girls actually just look different than boys, whether we're really unidentifying girls, and what it is about girls. Why did they look different? How do they look different? And, you know, how many are we really missing in terms of our diagnostics? One of the changes really is the number of individuals that we are now feeling have average to above IQs. Earlier on in the conceptualization of autism, most individuals with autism were seen to be functioning in the intellectually disabled range. And so it was thought that about 70 to 80% of people with autism were also intellectually disabled. And now the newest numbers are showing that 46% are falling in the average to above IQ range. And so that doesn't even count the IQs of 70 to 85, which aren't in the intellectually disabled range anyway, but 46% into the average to above range, which clearly tells us that a number of individuals on the spectrum are going to be capable of participating in post-secondary education programs, a number in traditional 2-year community colleges and 4-year colleges and universities. And we know that that also ranks all the way up to the gifted range of intelligence. We are still seeing, because if we conceptualize this as a social communication disorder, we are still seeing a number that are functionally nonverbal. Now, that doesn't mean that these individuals don't talk, but they don't have enough spoken language or use their speech in a way that is communicative. So we still have a lot of work to do in terms of giving individuals on the spectrum a way to communicate with other people, whether it's through technology or picture system or gestures, sign language, whatever. There is still a considerable number of people who are functionally nonverbal. When we look at the causes of autism, we still are missing a lot of information about what causes autism, how does it develop, why does it impact some people and not other people. But we are beginning to learn more about autism and its causes and its co-occurring disorders. So one of the largest areas of research in terms of financial expenditures and activity is in the genetics of autism. And that is impacting our thinking, because we know that we have a number of studies that show there is a higher rate of siblings who might have autism. If you have one child with autism, you are likely to have a second child at about 18%. If you have 2 children with autism already, it's 30%. And so we know that that is really very, very difficult. We know that there are genetic syndromes now associated with autism. And so people with Fragile X have very high rates of autism. Individuals with Down syndrome, that is a genetic syndrome, probably our most well-known genetic syndrome. And we never would have in the past talked about people with Down syndrome also having autism. We used to talk about children with Down syndrome falling into kind of 2 categories, those that were very friendly and social and those that were very stubborn. We used to talk about people with Down syndrome being stubborn, and really it's that those are the individuals with Down syndrome that may actually have the rigidity of behavior and the non-compliance that we see in individuals with autism. So studies show that about 5 to 7% of people with Down syndrome also have autism. Things like tuberous sclerosis, Angelman syndrome also have higher rates of autism than we would expect. We know that there's a relationship between fetal alcohol syndrome and autism. We know that autism can occur with metabolic disorders like phenylketonuria, which is one of those issues that newborn babies are all tested for. It's one of the things that when infants get their heels pricked in the hospital, they are checking for phenylketonuria. And with dietary manipulation and control, you can eliminate the effects of PKU and hence that cause of autism. And then we know that there are viral causes of autism. So when a pregnant mother gets viruses like rubella and like CMV, cytomegalovirus, that can result in autism in the child. And of course, you know, staying away from the issue of vaccines, rubella is well controlled now, and we don't see the kinds of epidemics of children born with very, very significant and multiple disabilities as a result of rubella. So blindness and deafness and intellectual disability and autism all occurring in the same children as a result of exposure to rubella. What do we know about co-occurring disorders? And I think, again, this is an area where we are now learning more and more about these co-occurring disorders. And so intellectual disability was previously and currently, I would say, you know, a very high co-occurring condition. Now, we saw that there are more individuals in the average to above range, but we are still seeing a pretty sizable number who are in the IQ below 70 range. So 45% about have co-occurring intellectual disability. Very high numbers now are being identified with additional mental health diagnoses like bipolar and anxiety, depression, and obsessive compulsive disorder, OCD. And some of the research shows up to 70% of people with autism have another co-occurring mental health diagnosis. The DSM-5, one of the additional changes that was made in the DSM-5 is that you could now have a diagnosis of autism spectrum disorder and also receive a diagnosis of attention deficit disorder. So in the DSM-4 and 4TR, if you had autism, it was assumed that attention issues were part of the autism. Now we're saying that you can have a separate attention deficit diagnosis. And in fact, research shows that 30 to 50% of people with autism have a co-occurring attention deficit disorder. Another co-occurring disorder, a very common one, is seizure disorders. And we see seizure disorders developing really at two different points in the life cycle. So some young children develop seizure disorders very early. And then we have a second onset of seizure disorders at puberty. And people aren't really sure why that second group of individuals do develop seizure disorders also. But as you can see, some of the research shows that up to 46% of people with autism also have seizure disorders. And when you combine seizure disorders and intellectual disability and autism and females, you have very high rates of early mortality. So that those four factors in combination are not really a good combination to have. The other area that is really getting a lot of attention right now is the area of adult issues. I think that as the numbers of people with autism was increasing, the focus really was on young children and the whole issue of early identification and early intervention. But now that all of those children are becoming adults, there is increased focus on adult issues and outcomes and what makes for more successful outcomes in individuals on the spectrum when they reach adulthood. We are seeing much more emphasis on employment as an outcome, and that emphasis is coming from public policy. It's coming from our educational system. It's coming from families who are recognizing all of a sudden that their children are getting older. And for some children, the promise of early intervention has not really panned out. I think that earlier on there was a lot of optimism about the benefits of early intervention. I think now we see there are a group of individuals, even with good, strong early intervention, continue to have challenging outcomes. But for many, there is more emphasis on employment. So we have WIOA, which is the Work Incentive and Opportunity legislation that really ensures that funding from vocational rehabilitation is kind of carved out and used for school-age children. And so we talk about pre-employment education and pre-employment programs, and they are being offered across the country to middle school and high school age individuals. We have the requirement really that sheltered employment and more segregated employment is not kind of the target for our outcomes, that we want as many people to take advantage of employment support in competitive employment settings. We're seeing models like Project Search, which is an employment training program that is usually a collaboration between school systems and an employer, a large employer in the community usually, Hospitals were the first settings, but now we're seeing project search sites in large corporations, universities, school systems, so that a group of older school students are getting trained on actual job sites, rotating through a number of job sites over the course of a year, being mentored by the employees on those job sites, and hopefully ending up with a job at that employer or another employer based on the experience those people have had. We see entrepreneurial options being developed, usually by parents. And I can talk about two that are in NSU's local area. One, the Chocolate Spectrum, which started out as a candy making business in a parent's kitchen, and now has turned into a site where you can take classes in chocolate making. There's a cafe there, expanded from just chocolate candies to pastries, and employs a number of individuals with developmental disabilities, not just autism. The parent who started this happens to be a speech language pathologist and actually had worked with individuals on the spectrum for a very long time before she had her own child with autism, and realized as he became an adult that there was really nothing for him. He's pretty significantly challenged, but she was able to do this and now is helping a number of other people. We also have the Rising Tide Car Wash that was started by a parent because his child had a big interest in cars. And so now they employ almost all individuals with autism, have opened a second location, and have been noticed on, national news programs like CNN. And then we're seeing also a larger variety of post-secondary educational programs being offered at vocational technical colleges, two-year community colleges, as well as four-year colleges and universities. One example is our college support program here at NSU called Access Plus, where our students are admitted to the university through the same admission requirements as any other student at the university, but they enroll in a specialized support program that provides services like a monitored study hall 2 hours a day, a peer mentor 10 hours a week, a weekly psycho-ed group. There are other college support programs that offer alternate programs. So students may not be working towards a regular college diploma at that college or university, but focus more on vocational outcomes and independent living outcomes. And you can see those kinds of listings on the Think College site, or search for autism college programs, and they'll come up also. So a lot of activity in the area of adult transition and adult services. We're also seeing a number of just trends and issues, I think, across the areas that are impacted by autism. And so in terms of our therapeutic interventions, our educational interventions, we're seeing new ways of looking at things and new ways of understanding the disorder and what will make things better for individuals on the spectrum. And so if we think about the old way that we used to deal with behavior, there were general interventions for any kind of behavior challenge. So no matter what the person did and the reason behind what they did, everybody got treated with the same interventions. The old way was being reactive. we didn't do anything until the individual demonstrated challenging behavior, and then our intervention was based on how we responded, what we did, and usually to punish the individual. The focus was on behavior reduction, getting rid of those difficult behaviors, and it was seen as a quick fix. What can we do to eliminate those behaviors? Well, now we are more looking at a positive behavior approach, and we are looking to match what we do to the reason why the behavior occurred. And so if the behavior occurred because the individual wanted to go outside, what we would do would be different than if he exhibited the same behavior because he wanted your attention, or because you were asking him to do some work and it was too hard, and so he ran out of the room. So now we want to understand why the behavior occurs and match our interventions to those reasons. It's a more proactive approach. We are more interested in preventing behaviors from occurring. The focus is on teaching new skills, because what the research has shown us is that the more skills an individual has, and especially communication skills, the less likely they're going to have to use behavior to kind of get their message across. Think about typically developing 18-month to 2-year-olds who have a variety of temper tantrums because they can't yet communicate. And that's the same for our individuals with autism who have communication issues. Their behavior is like a young child's temper tantrums. It's trying to send a message of, I want something, but I don't have the ability to get my message across. And the new way of looking at behavior is really focused on longer-term interventions and improving quality of life. And so, although I'm sure teachers and parents would still really like to have quick fixes, there's an understanding that it takes a long time to undo histories of behavior. The longer an individual has exhibited challenging behaviors that have gotten the job done for them, the harder it is to get them to give up those behaviors and use the new skills that they're being taught. And so we're really looking more at longer term interventions that are going to improve quality of life over time. In terms of social skills, what are we seeing in terms of new interventions and new way of dealing with the social deficits that individuals with autism have? So I think one of the bigger trends is in more peer-mediated interventions. So whether we are videotaping peers demonstrating skills, social skills that we want children to learn, or whether we are teaching peers in the moment how to respond to an individual with autism, we are using peers to build skills in the social area for our individuals on the spectrum. We are using more social cognitive interventions. And so we used to look at building kind of isolated social skills. How do you greet somebody? How do you take a turn with somebody? How do you answer somebody when they ask you something? But now we're looking more at how do you understand, how do you teach someone to understand that other people have different thoughts, thinking, and feeling than they have. And so Social Thinking by Michelle Garcia Winner has really, I think, taken on, especially for our higher functioning individuals on the spectrum. I think it's harder for our more complex learners with autism to understand social thinking, but I think for our higher functioning individuals, this is the way we get more generalization and more kind of use across settings and situations. We're seeing more use of technology to teach social skills and to teach other kinds of skills. There's evidence-based research on video modeling that is very strong. Our evidence on social skills instruction is not really so strong. So looking at some of these newer technologies and techniques, I think is going to get us further in the end. And using video modeling for a variety of instructional domains, teaching children to get dressed by watching other people doing it on video, or brushing their teeth, are all where we are. Trends in language and communication. There is clearly more emphasis on communication rather than speech. We used to talk about teaching kids to talk, and everybody waited for children with autism to talk. And now what we realize is it's more important that they understand that they can make things happen, whether it's through a picture communication system like picture exchange, or some kind of technology, speech generating devices, or using gestures more conventionally. But the emphasis clearly is more on communication than on speech now. There is incredible increase in technology use, I think because dedicated devices are much less expensive than they used to be. You used to talk about augmentative communication costing like $8,000 for a device. And now, of course, with the use of apps for iPads, for $1,000, you can set a child up with an indestructible case and the iPad and some designated apps. So there's much more technology use. It's much more socially acceptable. All children are used to using iPads, and so when someone uses an iPad to communicate, I think it's less unusual and they're more accepted. And of course, when we think about the relationship between communication and behavior, we know that not being able to communicate leads to more challenging behavior. And so the earlier we can introduce augmentative and alternative communication, the less likely it is that the individual is going to develop challenging behavior. In the old days, we used to talk about waiting till age 5, and if a person didn't develop speech by age 5, then we would introduce augmentative communication. That is not the case anymore. Now we are introducing augmentative communication at very early ages. In terms of trends in education, earlier diagnosis leads to earlier intervention. I think we're seeing more children on the spectrum being picked up between even 15 to 18 months of age and getting involved in the Part C birth to 3 programs. Again, earlier diagnosis leads to early intervention. Earlier intervention does lead to better outcomes for a sizable number of individuals. We're seeing much more specialized training for teachers and other school staff. Earlier on, very few school districts had people who were expert in working with individuals on the spectrum, and I would say at this point in time, many districts have specialized people who are able to support teachers and paraprofessionals. We are seeing many more instructional aides. In the earlier times, aides were more kind of custodial and did things like, dressing kids and toileting kids and making photocopies. Aides are now instructional, and so they need to be trained to be able to provide the instruction, whether it's in a general education classroom or an aide in a special education classroom, whether the aide is assigned to an individual student or whether they're working with groups of students, they require the training and support that is necessary to be effective interveners. I just want to kind of, before we open up for questions and answers, talk a little bit about some of our programs here at NSU, at the Mailman Segal Center. We start our children in our diagnostic developmental assessment clinic, where we see children usually starting at 18 months of age to look at whether there's a diagnosis of autism that can and should be made. Our Starting Right program is a parent-child early intervention program. Unlike a lot of Part C programs that go into homes or go into child care centers, we bring parents together as a group with their child in a classroom setting so that it's one-to-one, because everybody's got a caretaker of some type. Could be a grandparent, could be a babysitter. And then there are staff people who are coaching those caregivers through the centers in the classroom. They come to school two mornings a week, and every other Friday they have 2 individual sessions, one a discrete trial teaching session and one using pivotal response training. For preschoolers, we have our Baldwin Preschool. It's our first program, started in the 1980s. Now serves 145 preschool children under a contract with Broward County School System, so families don't have to pay to attend the preschool. And then we have a private option for children who are not able to attend the Baldwin Preschool, or for kindergarten children, called the Academy. Our newest program really is our college support program, our Access Plus program, where we support NSU students who are on the spectrum who are admitted through traditional application procedures. We have a couple of other clinics in the building. We have a challenging behavior clinic for children up to about age 8, or as long as we can physically manage them appropriately. A feeding disorders clinic, which right now is under a state appropriation, and so any child who's able to get accepted into that clinic is not charged for services until June 30th. And then we have a pediatric dental clinic here that's training dental residents in how to work with individuals with autism. The Autism Consortium provides training and support to school systems around the country. And so that's kind of our suite of Mailman Segal Center programs. The university does have other clinics that are focused on individuals with autism, as well as a branch of the University of Miami NSU Center for Autism and Related. And then I'll leave this slide up for more information. You can contact me or anybody else here at the Mailman Segal Center.
Well, Sue, thank you so much. That was an excellent presentation with so much information. I'm just looking to see if anybody has any questions that they'd like to throw out there or for discussion. You could use your chat section of this webinar to send in some questions. In the meantime, while we wait for some, I thought of a couple that maybe we could talk about, Dr. Kabot. I guess if you're, what are the most important steps in early intervention when you get that diagnosis, or when you think something there might be a delay, or you're just not sure what's going on? If somebody was to start out now, I guess what would be some information you might share?
I mean, I think that if you're a parent and you're seeing some signs, or maybe a family member has said something to you about, seeing some things in their niece, nephew, grandchild, neighbor, the first thing clearly is to talk about it with your pediatrician. Now, pediatricians get a bad rap because earlier on, I think there was not a lot of information, and pediatricians were taking the wait and see attitude. And he's a boy, boys talk later, come back in 6 months. But I think now there's enough awareness that most doctors are aware of autism and the importance of early identification. And I think that early intervention systems have done a good job of getting the word out. And so I would say that is where to start. But if, in fact, that person does not kind of encourage you to look further, I wouldn't necessarily take their answer as oh, that's a relief. Now I don't have to do anything. You can always contact Child Find, your early intervention Part C provider, to have your child screened at no charge. And their job, Child Find's job, they are tasked with picking up individuals with disabilities. Now, we even see sometimes where a child will get through the Child Find screening, especially if they're higher functioning and they're verbal. But when you see them in their child care setting, for example, you can see the more social, independent, unusual behaviors cropping up there. So even then, I think parents generally know best. And if a parent is uneasy, I would encourage that parent to continue to exhaust any resources that are in that community. And to take advantage of the free services through early intervention. It's also really important to understand your insurance, whether you have private insurance or Medicaid. Most states now have an autism insurance mandate. Each state is a little different in terms of what that covers for autism, but for many people it does cover behavior analysis services, speech language therapy, occupational therapy, and parents should really take advantage of those services that they have accessible to them also.
Well, thank you, Dr. Kabot. That's a lot of great information. I don't have any other questions coming in. I guess I can just ask one more question, just to talk about. There were so many great changes that you talked about in the presentation, and it sounds like there were such positive new methods out there. Is there any one important change that comes to your mind that just was just so impactful, or just such a positive, I don't know, anything that stands out that you'd want, I don't know, to focus on?
Well, I think really, I think that the more positive approach to behavior and taking the approach that it's important to build skills and show people what are the appropriate things to do, as opposed to punishing children for inappropriate things. Because when you punish them, you're not really giving them an alternative. When you are reinforcing them for good behavior, when you're teaching them new skills and they're using those skills are going to last them a lifetime. So I think that shift from a more punitive approach to a more positive approach probably has the biggest impact. And the recognition that communication and behavior are inextricably intertwined, I think also is very important.
All right, well, thank you very much. We don't have any other questions coming in. I'd like to remind everybody you can find the webinar online if you wanted to tell any of your friends or family or anybody that you think can benefit from this webinar. If you just go to www.nova.edu//DRA and click on events when you get there, and go into the webinar archive, and it will be there. We thank you very much, everybody, for attending the webinar, and we hope it was helpful to you. Have a great day.